From Redfield Medical Direction, I am Lynn Nguyen, Associate Medical Director, and this is your EMS Protocol Review. Abdominal pain is one of the most frequent complaints seen in EMS. At least 1 in 20 911 calls are for abdominal pain. And yet, these calls can be the most deceptively dangerous complaints we see. Nearly 60% of the patients who are 60 years and older end up being admitted to the hospital, and almost 1 in 5 of them need surgery. And the kicker? They have perfectly normal vital signs in the first 10 minutes. You've all seen it, the patient that looks fine until they aren't. Your goal isn't to memorize all the possible causes of abdominal pain. For these patients, you should consider thinking a little differently. In trauma, we're always differentiating patients by mechanism. For medical patients, we should think by syndrome. So when you're standing over that patient who's clutching their stomach, your internal question shouldn't be, is this appendicitis or not? Instead, it should be, is this patient bleeding, infected, or ischemic? Those are the triad of time-critical abdominal catastrophes. Every question you ask and every vital sign you trend should help you decide which category your patient is drifting towards. You're not diagnosing, you're dispositioning, buying time with the right interventions and getting the patient to the right destination. When assessing a patient with abdominal pain, keep an eye out for the quiet, still patient. They're guarding because motion hurts and they're afraid to breathe. Contrast that to the patient with the classic kidney stone who just can't get comfortable. They're writhing around and trying to climb off the stretcher. Make a note of and document any surgical scars, ostomy sites, or medical device. Every tube or port is a potential source of infection or obstruction. Make sure you check distal pulses. A weak left pedal pulse in a patient with pain that radiates to the back might tell you more than any story that they can give you. When palpating, your goal is not to reproduce the agony, you're gauging the character of the pain. If they wince with gentle touch, that could be peritoneal irritation and not just tenderness. Sometimes the best diagnostic maneuver is simply making a note that the patient has pain with every bump in the road. That's rebound tenderness you didn't even have to cause. Finally, just step back. Ask yourself, does the physical exam match the story? If the pain is excruciating but the abdomen is soft, you're staring at possible mesenteric ischemia. If the abdomen is bored hard but the patient minimizes it, think of the elderly, the immunosuppressed. Their exam findings are typically blunted when compared to their younger, healthier counterparts. The exam doesn't give you an answer, it gives you a pattern to fit into your risk model. A high heart rate can help you further risk stratify your patient. Tachycardia can be due to so many different things. It might be the pain, it could be dehydration, or it might be your first and only whisper of intra-abdominal hemorrhage. Patients can lose up to 15% of their blood volume, and you might not see anything overtly obvious on your exam. The patient may be vaguely anxious or say that they're a little thirsty. Their blood pressure and skin still look normal at this point. This is the complacency zone for hypovolemic shock because there are no obvious signs just yet. When patients approach losing a third of their blood volume, the body's compensatory mechanisms become a little more noticeable, with a tachycardia ranging between 100 to 120 and a narrow pulse pressure. The skin starts becoming cool, a little pale, and the patient might be a little diaphoretic. Hemodynamic compensation starts failing by stage 3, as evidenced by the definitive hypotension. The loss of perfusion might result in some mental status changes, either restlessness or less responsiveness with a blank stare. Stage 4 is profound decompensation and unresponsiveness. Ideally, we would have identified the hypovolemia and started intervening before this point. This is why trending vital signs is everything. Look at the direction of the trend, not just a single data point in time. A heart rate drifting from 88 to 104 over 10 minutes is more meaningful than a single blood pressure reading of 122 over 78. Don't let a set of normal numbers lull you into missing early shock. If the patient is breathing fast but doesn't have any signs of respiratory distress, that's not anxiety, that's acidosis until proven otherwise. So when you see that combination, a patient breathing 28 times a minute with clear lungs, the question is, why are they blowing off CO2? It's because that's your DKA patient, or septic patient, or bowel perf. Abdominal pain evolves fast. A soft abdomen at minute 1 can be rigid by minute 15. So your reassessment is the real diagnostic tool. Trend your vital signs, repalpate gently, and re-ask about the quality of pain. The story unfolds when you're on scene and en route, if you're watching for it. Write your note like a time lapse, not a snapshot. The moment you think, oh, it's just gastritis, your brain stops scanning for danger. Anchoring is our enemy, and this is where we lose people. Instead, ask yourself, what's the worst thing this could be, and does my exam rule it out? That one question keeps you honest and humble. These are the misdiagnoses that bite us in QA reviews. The patient with nausea, epigastric pressure, and minimal abdominal tenderness who ends up being an atypical MI. The young female who actually had her period a few days ago, now with severe suprapubic pain because of an ectopic pregnancy. Many of these patients don't even know they're pregnant and might even tell you they had a negative pregnancy test at home. And last but not least, the 50-year-old with kidney stone type pain and a distal pulse that you can't quite feel on one side because of his worsening abdominal aneurysm. These are your quote-unquote zebras, except they're not that rare you see enough cases of abdominal pain. Now let's wrap up by talking about one of the longest-lived myths in emergency medicine. For decades we were told, don't give morphine, you'll ruin the exam. This concern came from early 20th century surgical teaching, the idea that pain localization guides the surgeon and any sort of pain medication might blur it. It's extremely outdated. Modern data tells a different story and shows that a comfortable patient gives you a better history, thereby helping the clinician distinguish between pain and peritonitis. A 2004 study tested whether giving morphine to patients with suspected appendicitis would alter their exam findings. In this randomized double-blind trial, patients received morphine or placebo before surgery, and exam findings were compared. The results showed clear pain relief reported by patients without significant change in their physical exam findings. In other words, giving morphine made patients more comfortable without masking the signs of a surgical emergency or confusion of the diagnosis. Another study was done in 2008 and showed similar findings. Pain medicine made patients feel better and did not change the surgeon's treatment plans. A 2019 systematic review and meta-analysis looked at whether giving opioid pain medication to patients with undifferentiated abdominal pain made it harder to reach the right diagnosis. Across 12 randomized studies involving over 1,300 patients, no increase in diagnostic errors was found when opioids were used compared to placebo. As a bonus, patients who received opioids had significantly better pain relief without masking serious surgical problems. So what does this mean for us pre-hospital? Analgesia is therapeutic and diagnostic. A calm, communicative patient tells a better story. It's also humane. Uncontrolled pain drives tachycardia and catecholamine stress, worsening ischemia or bleeding. Use opioids judiciously. Titrate, reassess, and document the effects, but don't withhold them out of fear of masking the symptoms. In short, comfort doesn't cloud judgment, it clarifies it. Treat the pain, reassess dynamically, and note the response. If pain relief unmasks peritonitis or improves cooperation, you've gained diagnostic data, not lost it. Pain control isn't the enemy of good medicine, it's a part of it. And that's all we have for this episode. This is a production of Redfield Medical Direction. This episode was produced by me, Lin Win. The theme music is by Infraction. As always, don't hesitate to reach out if you have any questions. See you next time.